Hello and welcome. I'm Dr. Rita Nanda. On behalf of Creative Educational Concepts, thank you for joining us for today's educational activity. This is one of a three-part activity series. Here we focus on efficacy of the antibody drug conjugates. One of the other activities focuses on the mechanism of action of antibody drug conjugates, and another focuses on toxicities and toxicity management. Today's program is supported by an independent educational grant from Gilead Sciences Incorporated. This activity may include discussions of products that are not currently FDA approved for all indications that we discuss. Again, I'm Rita Nanda, an associate professor of medicine and director of breast oncology at the University of Chicago Medicine in Chicago, Illinois. Joining me today is Dr. Reshma Matani, Chief of Breast Medical Oncology at the Miami Cancer Institute, Baptist Health, South Florida, in Miami, Florida. We have one learning objective for today's short program: selecting ADC therapies for the treatment of patients with HER2-negative metastatic breast cancer based on guideline recommendations, expert consensus, and clinical trial findings. I'll start today by introducing you to Michelle Benjamin. Ms. Benjamin currently is living with metastatic triple-negative breast cancer. She has graciously allowed us to use her case to highlight our educational agenda.
My name is Michelle Anderson Benjamin. I am a mom of two, currently 41 years old. I have an 18-year-old son that's graduating high school and an 8-year-old daughter that's going to third grade. Just a little brief history of me. I was initially diagnosed in 2020 at the age of 36 with stage 1 triple-negative breast cancer. No family history, no lump. I just had side effects of my breast discharging blood, and I knew that wasn't normal. And I work in healthcare, so I knew, what steps I needed to take. And, that got it confirmed that it was breast cancer. And because of my age and no family history, I am the fact that my breast was leaking blood. I had my breast removed first and then went into treatment. And at the time, triple negative, which is one of the most aggressive subtypes, didn't have a lot of options. So I did ACT, dose dense, which means I went to treatment every other week. And I had Taxol and the Red Devil. A lot of the side effects of those two treatments were explained to me, but they're not necessarily the ways to try to cope with those feelings or emotions, or actually the side effects in itself. So I educated myself and got connected with other organizations and wound up starting my own. Currently, at the age of 38, I had a reoccurrence, and it discovered that my stage 1 turned into stage 4.
There are currently 3 available antibody drug conjugates, which are FDA approved for the management of HER2-negative metastatic breast cancer. These include sacituzumab govitecan and datopotamab deruxtecan, which are both TROP2 targeting ADCs, and then trastuzumab deruxtecan, which is a HER2 targeting ADC. All of these ADCs have a toxic payload, which is a topoisomerase 1 inhibitor. Please participate in the other activities that are part of this series to learn more about these ADCs, their mechanism of action, and side effects. In preparing to receive ADCs, patients want to know what kind of benefit they'll receive from these agents. Please listen to Ms. Benjamin again share her perspective on this important question.
How effective are ADCs, and what are the expected outcomes? Be realistic. You can give the statistical numbers of those things, but also, give them just a brief understanding of maybe other patients that you may work with or deal with, and how their, some outcomes and some struggles they may have encountered with this type of treatment.
And on that note, I would now like to turn it over to Dr. Reshma Matani to talk about antibody drug conjugates for the management of metastatic triple-negative breast cancer. Reshma?
Thank you, Rita. And as Ms. Benjamin correctly talked to us about and brought up was the importance of understanding how these agents fit into our treatment paradigm, not just from an efficacy perspective, but also from a tolerability perspective, and understanding how these agents may be utilized for our patients that have metastatic breast cancer. So here you see a summary of the phase 3 ASCENT trial, which led to the approval of sacituzumab govitecan in the second line and later metastatic TNBC setting. This was an important study because it compared the ADC against treatment of physician's choice, and the ADC and the treatment of physician's choice both were continued until treatment or unacceptable toxicity, with the primary endpoint being progression-free survival. So the important point to emphasize here is that the ADC outperformed treatment of physician's choice, with significant improvements in both progression-free survival and overall survival over single-agent chemotherapy. As we think about the benefits that we've seen with antibody drug conjugates, specifically with this agent in the metastatic TNBC setting, it's important to recognize that this is an area of high unmet need, as our patients with metastatic TNBC who were receiving single-agent sequential chemotherapy prior to the advent of ADCs did quite poorly overall, and this drug represented a significant improvement. Rita, do you want to take us through the information about the clinical benefit per biomarker expression?
Yeah, so, in the ASCENT trial, they evaluated TROP2 expression levels and correlated this with response to therapy. They also looked at HER2 low, HER2 zero disease. And the bottom line is, in the ASCENT trial, regardless of the level of TROP2 expression, whether it's low, medium, or high, patients benefited more from SG as compared to chemotherapy of physician's choice. So what that tells us is that we don't need to look for TROP2 expression levels to determine who is a candidate for SG versus chemotherapy, because SG outperforms chemotherapy regardless of the level of TROP2 expression. And this was also true based on HER2 IHC expression, regardless of whether patients were HER2 low or HER2 null. They similarly benefited more from SG as compared to chemotherapy of physician's choice. So really no biomarker that's going to help us identify who an appropriate patient is for SG. We just know that SG is better than chemotherapy for patients with metastatic triple-negative breast cancer. So really exciting to know that this therapy is available for all triple-negative patients, regardless of expression levels. So Reshma, can you also talk to us about hormone receptor positive metastatic disease? And I think we've got some data with SG in that space as well.
We do, and we have an approval for SG also in hormone receptor positive metastatic breast cancer based on the TROPiCS-2 trial. This was a trial that included patients that were heavily pretreated with at least 2, but no more than 4 prior lines of chemotherapy. And again, to put this into context, prior to the advent of ADCs, we were usually treating patients with single agent sequential chemotherapy drugs that were with decreasing efficacy and accumulating toxicity as we continued to expose our patients to these treatments. So here in this important trial, again, the ADC, in this case SG, was compared against treatment of physician's choice in a heavily pretreated population of patients with hormone receptor positive, HER2 negative, meaning IHC 0, 1 plus, and 2 plus, and ISH negative or not amplified. And what an important point to highlight here is that the chemotherapy of physician's choice options were drugs that we would normally be reaching for in this setting. And again, here we saw that the ADC outperformed treatment of physician's choice with an improvement in both progression-free as well as overall survival, which again, I think in this heavily pretreated population is extremely clinically meaningful. And then moving on, do you want to take us through the data with TDXD in this space?
Yeah, sounds great, Reshma. So obviously the Destiny Breast 04 clinical trial was a trial that was performed around the same time as the TROPiCS-02 trial. And in this trial, patients with predominantly hormone receptor positive disease, although 10% of patients who participated in this trial did have hormone receptor negative disease. In this trial, patients who'd had 1 to 2 prior lines of chemotherapy for advanced stage disease were randomized to TDXD versus chemotherapy of physician's choice, with a primary endpoint of PFS and secondary endpoints, including overall survival. And patients were eligible for this trial if they had some degree of HER2 expression. So they needed to be HER2 low, so HER2 IHC 2+ or 1+, and non-amplified by FISH. And what we saw in the Destiny Breast 04 trial was a very statistically significant and meaningful improvement in both progression-free survival as well as overall survival. So this has really changed the landscape of how we treat patients with HER2 low hormone receptor positive disease. And, you know, we've got subsequent study, the Destiny Breast 06 trial, which looked at trastuzumab deruxtecan in an even earlier line of therapy. Here, Destiny Breast 06 focused on hormone receptor positive disease only, but included both HER2 low as well as HER2 ultra low disease. HER2 ultra low disease is defined as some degree of HER2 staining that doesn't quite meet the threshold for being IHC 1+. And in Destiny Breast 06, this was a frontline trial. So patients with hormone receptor positive metastatic disease who'd not previously received chemotherapy were randomized to trastuzumab deruxtecan versus chemotherapy of physician's choice, with a median progression-free survival primary endpoint, with a whole host of other secondary endpoints, including overall survival. And Reshma, I don't know if you want to talk a little bit about the data from Destiny Breast 03. Sorry, Destiny Breast 06.
Sure, happy to. So as we saw in this first line trial using TDXD for patients that are receiving chemotherapy in the first line setting versus treatment of physician's choice, again, not surprisingly, we saw an improvement in progression-free survival in the intent to treat population, in the HER2 low population, as well as those 150 patients that had HER2 ultra low disease when comparing TDXD against treatment of physician's choice. We saw improvements in 12-month overall survival, we saw improvements in median progression-free survival with TDXD as compared to treatment of physician's choice. Of course, we're awaiting survival data in the first line setting with TDXD. Not surprisingly, we also saw improved overall response rates favoring TDXD as compared to treatment of physician's choice. There certainly are patients that may be appropriate for TDXD as first line therapy. And I think that for our patients, it's great news that we now have access to this extremely efficacious drug in the first line setting for the correctly selected scenario.
Yeah. And what about datopotamab deruxtecan? Do you have some experience with that? Could you walk us through the Tropion Breast 01 study?
Sure. This is now an area where it's becoming a crowded space. And again, that's good news for our patients because it means that there are more and more options. As you pointed out earlier, Rita, datopotamab deruxtecan has that same chemotherapy payload deruxtecan as trastuzumab deruxtecan does, but it targets TROP2 as opposed to HER2. We now have this agent approved as well based on this important study, the Tropion Breast 01 trial, in which patients with hormone receptor positive, HER2 negative, again, that means HER2 null as well as HER2 low, patients received datopotamab deruxtecan versus investigator's choice chemotherapy. These patients had 1 to 2 prior lines of treatment. And as we have consistently demonstrated in all of these trials now, the ADC outperforming the chemotherapy arm. Here we saw an improvement in median progression-free survival. A survival benefit was not demonstrated.
So that's really exciting. I agree with you, Reshma. It's so nice to have all of these different options for our patients. So just to recap, for patients with hormone receptor negative disease, we've got sacituzumab govitecan, which is approved for patients with all forms of triple negative breast cancer. There's no biomarker that helps us select out these patients. And for hormone receptor negative disease, that's HER2 low or ultra low, we also now have trastuzumab deruxtecan available for use. For patients with hormone receptor positive disease, we've got even another agent. We've got datopotamab deruxtecan now, in addition to sacituzumab govitecan. And both of these ADCs are TROP2 targeting ADCs with a topoisomerase 1 payload, as well as trastuzumab deruxtecan, which is approved now even in that frontline metastatic setting. So really exciting to see all of the advances. There are obviously emerging ADCs. We have a HER3 targeting ADC called patritumab deruxtecan. Again, that same deruxtecan payload, but here targeting HER3, which has shown some promising efficacy in all the different subtypes of breast cancer, including hormone receptor positive, HER2 positive, as well as triple negative disease, with a response rate in triple negative breast cancer of about 43% in a small patient population, and about 30% of patients with hormone receptor positive HER2 negative disease appeared to have a benefit. So there are larger randomized trials that are being planned with this HER3 ADC. So really, really exciting space. Reshma, do you want to talk to us a little bit about the NCCN recommendations for how to use antibody drug conjugate therapy for metastatic disease?
Sure. So first, starting with hormone receptor positive, HER2 low or HER2 negative metastatic disease. Now, as I mentioned earlier, we have the opportunity to use systemic chemotherapy as always. This has always been an option for first-line chemo, but now we also have the consideration to utilize T-DXd based on the DB06 data that you took us through in the first-line setting. In the second-line setting, if a patient has HER2 low disease, T-DXd is considered category 1. For those patients that are HER2 IHC ultra low, T-DXd can also be utilized in that setting. If they're not a candidate for T-DXd, we would consider sacituzumab govitecan in that space. Of course, for triple negative breast cancer patients, one of the most important biomarkers to assess in the first line setting is PD-L1 status, as we have an approval for pembrolizumab in combination with chemotherapy in the first line setting for TNBC patients, and systemic chemotherapy for the PD-L1 negative. Of course, we heard some important data at ASCO this year that may change what we do in the first line setting for metastatic TNBC patients. Currently, after one line of treatment, we have the opportunity to use sacituzumab govitecan. We went through the ASCENT data. This was really important, an important step forward for our patients who to date had limited treatment options. And then, as you pointed out, T-DXd also has some data, although not as great in numbers, based on the DB04 trial that included those 63 patients that had ER negative HER2 low disease, essentially triple negative disease, and there's an opportunity to utilize T-DXd in that space as well.
Thank you so much, Reshma, for that wonderful summary. It's really exciting to think about all these ADCs that we've got available for use. I think what we don't know and remains to be seen is, can ADCs be sequenced effectively? And is there a best strategy for how to sequence these agents? Obviously, for the HER2 targeting ADCs, we've got biomarkers, either HER2 low or HER2 ultra low, although studies in HER2 null are ongoing, so that very well could impact clinical practice down the road. We always think about clinical factors specific to the patients that might impact their ability to tolerate one ADC over another. And if, one may not be a reasonable strategy for patients based on their comorbidities, obviously is something we always take into account. But, I think what we know from real world analyses of sequencing studies of ADCs is that, we unfortunately don't see as much efficacy with the second ADC that's given in the sequence. And so, most of the ADCs, or all of the 3 ADCs that we've talked about today, have similar payloads. They're not the exact same payload, at least for sacituzumab and the deruxtecan payload containing ADCs, but they are of the same class. They are topoisomerase 1 inhibitors. And, there's a sense that a big component of resistance to an ADC is payload resistance. And so I think looking to the future, incorporating ADCs with different toxic payloads is going to be really important. And if that might help us have more efficacy by sequencing ADCs. But as of right now, we don't have great information on which ADC to start with, which one to go to in the second line setting, and is there a best way to sequence these agents, and should we sandwich therapy, giving a break in between one ADC and another? All of this is unknown, and there are trials ongoing now trying to help us address those concerns. So now let's hear from Ms. Benjamin again. Ms. Benjamin, please share your thoughts.
Can ADCs be combined with other treatments? Very important to explain if patients are able to take immunotherapies with the ADCs or not, and also what other things they should avoid.
Yeah, Reshma, would you like to comment on the concerns that Ms. Benjamin raises?
Sure. So I think this is something that we're all very interested in as we look to the future of how these agents may be developed and combined with other drugs. Combining ADCs with other therapies in metastatic breast cancer is based on synergistic mechanisms that aim to enhance efficacy, overcome resistance, and improve durability of response. So there is a thought that combining ADCs with immunotherapy may boost anti-tumor immune responses, particularly in triple-negative breast cancer, as we've seen, and pairing ADCs with, for example, PARP inhibitors, which leverages the DNA damaging effects of ADC payloads and exploits synthetic lethality in tumors with BRCA mutations, may be a reasonable strategy. Of course, we've seen some data in HER2-positive disease with combining ADCs with other agents, which hopefully will lead to newer combination strategies for HER2-positive disease as well.
Yeah, thanks. That was really comprehensive. And obviously, resistance to ADCs is important to understand. Could you walk us through some of the mechanisms of resistance to ADCs? We had a really nice program earlier today where we covered the mechanism of action of ADCs, but I think at the same time, it's really important to think about what are the mechanisms of resistance to these therapies.
It's the question of the hour, I would say, as we have more and more of these drugs. Understanding how these tumors become resistant to these drugs is something that we're going to have to do a lot of work to clarify these mechanisms. I think a lot of this will be done based on correlative work in a lot of the trials that we're doing with pre and post biopsies. We have to try to understand if there's resistance to the target, to the payload, to both. Or should we, as you mentioned earlier, try something different in between, as we call sandwich therapy? I think we think of these drugs as having a modular design, the antibody, the payload, the linker, but these are really complex agents. And with that in mind, there's an opportunity to understand various aspects of how these drugs are working as we think about resistance. So of course we have binding of the antibody drug target of the ADC rather to the target on the cancer cell surface, and there may be mechanisms at play there that could lead to resistance in terms of target downregulation or mutation or masking of the binding site. Then these drugs are internalized, and that mechanism is also another thing to think about in terms of altered intracellular trafficking as the drug is brought into the cell. Then there's, of course, lysosomal degradation of the ADC and the payload release. So aspects in terms of reduced lysosomal proteolytic activity may be at play in terms of a resistance mechanism. So there are various aspects as we follow these drugs through the cell and the payload being released that can be potential mechanisms of resistance. I think it points to the fact that there is so much more work that needs to be done to understand what seemingly seems like a simple modular drug design, but is clearly more complex.
Thank you so much, Reshma, for sharing your immense knowledge with us about ADCs. It's been really wonderful to summarize this for our audience at home. I think, I'm just going to end the last few minutes just by talking about the need for a team-based approach for the management of patients with cancer. Obviously, we know that it takes a village to take care of patients with cancer, from the healthcare team to the caregivers to other support staff, as well as other disciplines. When we talk about some of these antibody drug conjugates and the unique and distinct toxicities they have, eye toxicity, GI toxicity, pulmonary toxicity, it's really important to pull in other disciplines and help educate them all and have them help us manage patients who experience some of these toxicities. I'd also like to leave you with SMART goals, which, as a refresher, are smart, measurable, attainable, relevant, and timely goals, which are designed to help you implement these new data into your clinical practice right away. And before we end the program, I also wanted you to know that Ms. Benjamin, who shared her breast cancer journey with us here today, received an antibody drug conjugate in the context of a clinical trial. She's been on this agent for over a year and a half now and is tolerating therapy very well and is living her life to its fullest. Per protocol, she has had a dose modification to her drug, but continues to remain in good response, and shared with us that she recently took her daughter to a Beyonce concert. So really just living her best life. Again, today's program was the second of a three-part activity series discussing antibody drug conjugates and their use in HER2-negative metastatic breast cancer. I hope you'll join us for the others. I'd like to thank CEC Oncology for providing today's program, as well as Reshma for joining me and sharing her knowledge of antibody drug conjugates and the clinical data that help us incorporate these antibody drug conjugates into our clinical practices. And most of all, I'd like to thank you, our audience, for providing the very best care